This video is made for educational purposes only. Please consult current references before providing any advice to your patients. Welcome back to Pharmtastic 4. Today's video is on glaucoma. Today's topic is glaucoma. Glaucoma is a type of neuropathy that damages the optic nerve. There are many different types and classifications of glaucoma. What we most commonly see in a community pharmacy, though, is so-called open-angle glaucoma. The disease leads to progressive vision loss and may result in irreversible blindness if not treated on time. Today, we will discuss the topical pharmacological options of eye drops for the treatment of open-angle glaucoma. Various systemic, topical implants, laser and surgical approaches exist, but this will not be covered in this video. A little bit of anatomy recap. The eye has three chambers filled up with fluids. The anterior chamber is between the cornea and iris. The cornea is a very superficial layer of the eye, and the iris, that's what gives our eye color. The iris is perforated in the middle. This is our pupil. When the iris constricts and relaxes, it changes the size of the pupil, so more or less light goes into the eye. The posterior chamber is between the iris, the colored muscle, and the lens. And there is also a vitreous chamber between the lens and the retina. The vitreous chamber is filled up with a gel-like fluid, and it gives our eye its ball-like shape. The aqueous fluid of the anterior and posterior chambers is constantly being produced and reabsorbed. Those processes are responsible for the maintenance of intraocular pressure. The aqueous fluid is being produced by the cells of the ciliary body, the structure that lies in front of the vitreous chamber and is partially attached to the side of the lens. The fluid is secreted into the posterior chamber and circulates between the anterior and posterior chamber through the pupil. The lens and the cornea don't have blood supply, so the aqueous humor brings nutrients and oxygen to the structures and washes away the products of its metabolism. Reabsorption of aqueous humor is done in the anterior chamber with little tubes called trabecular meshwork, acting like a sponge to absorb the fluid. These tubes collect liquid into the Schlemm's canal, where it goes into the blood vessels. The ciliary muscle is responsible for making the fluid flow into the Schlemm's canal. The ciliary muscle, a part of a ciliary body, regulates the shape of the lens when we try to focus our vision. The topical treatment options of glaucoma aim to achieve a decrease in intraocular pressure by either the reduction in aqueous humor production by the ciliary body, for example alpha-2 agonists, beta blockers and carbonic anhydrase inhibitors, or increase its outflow. Prostaglandins alpha-2 agonists and cholinergic agonists target this pathway. When we talk about open or closed angle glaucoma, we refer to the angle of the reabsorbing tubules in the anterior chamber, the angle between the iris and cornea. In the closed angle glaucoma, this mesh network is blocked, the angle is closed, and that is why reabsorption of aqueous humor doesn't happen. This normally leads to a sudden increase in intraocular pressure and is a medical emergency. Open-angle glaucoma is a chronic progressive disease. It is characterized by anatomically correct positions of the eye structures involved in the circulation of the fluid. However, for various reasons, some of which are still a mystery to medical professionals, the circulation of the fluid is affected. In most cases, glaucoma is accompanied by an increased intraocular pressure, and this increase is the only modifiable risk factor that can preserve the vision, if addressed in a timely manner. At the same time, not all patients suffering from increased intraocular pressure will develop optic nerve neuropathy, and some patients will develop neuropathy even if their intraocular pressure is within normal range. The suggested mechanisms for optic neuropathy is physical compression and subsequent ischemia of the optic nerve. Exact mechanisms are still under investigation. The treating doctor will have to use their clinical judgment to decide when to treat and how aggressive the treatment should be. The majority of healthy people would have an intraocular pressure below 21 mm of mercury, and the risk of glaucoma rapidly increases as the readings rise. The intraocular pressure targets vary for different patients, normally around 25–30% below their initial reading. The target intraocular pressure depends on the examination of the optic nerve, how rapid the progression of the nerve damage is, and how significant the visual loss is. Patient's age, family history, comorbidities, and many other factors will also be taken into account. Bringing the intraocular pressure down has shown to be very effective in preserving the optic nerve. It is also very important to point out that the response to pharmacological treatment is not instant. Ideally, we want to check the response to the medication in 3 to 4 weeks and then in 2 to 4 months. The drops are normally discontinued if after the trial period there is no significant reduction in intraocular pressure. Sometimes the patients will be advised to start treatments in one eye only, so the other eye is left as a control to see if the drops are working. If the intraocular pressure gets reduced in the treated eye and not in the control eye, the treatment is concluded to be effective and will continue in both eyes. If the patient has only a partial response to the first-line treatment option, the doctor may add a second medication. International guidelines debate if replacing one medication with another from the same class is effective. In Australia, we sometimes see different prostaglandin analogues tried if the first representative of this class doesn't provide satisfactory results. Let's now have a look at what medications are used in Australia. One of the first-line treatment options are prostaglandin analogues. It is the most effective class of medications in lowering intraocular pressure. This class works on the level of the ciliary body, increasing the outflow of aqueous humor. This drug class has mostly topical side effects. Prostaglandin analogues may cause hyperpigmentation of the iris and eyelashes, increasing the length and thickness of eyelashes, changes to the tissues around the eyes, given the tired look, dark circles, and loss of the fat tissue around the eyes. Common complaints of the eye irritation are thought to be caused by a preservative. A few drops now have a preservative-free option. In addition, prostaglandin analogues may cause or worsen existing inflammation in the eye, such as iritis, uveitis, or herpetic keratitis. The prostaglandin analogues available in Australia are bimatoprost, latanoprost, tafluprost, and travoprost. The next class is beta blockers. Beta blockers work by reducing aqueous fluid production by the ciliary body. They have lots of adverse effects due to their systemic absorption: bronchoconstriction, bronchospasm, hypotension, bradyarrhythmia, reduction in cardiac output, and they may be contraindicated in patients suffering from pulmonary or cardiac disease. As beta blockers cross the blood-brain barrier, they may also cause anxiety, depression, and sleep disturbances. Sexual dysfunction is another side effect that many patients may not feel comfortable to discuss or may not relate to the use of eye drops. Beta blockers interact with other medications that cause bradyarrhythmias and should not be used in patients taking verapamil. Representatives are betaxolol and timolol. Timoptil is used twice a day, and the XE formulation, a gel-forming drop, is used once a day only and may cause less systemic adverse effects. Timolol is a non-selective beta blocker, and betaxolol is beta-1 selective beta blocker. Beta-1 selective agents are preferred in patients with respiratory comorbidities, but might not be as effective. Now moving on to alpha-2 agonists. Alpha-2 agonists are the second-line treatment. They have double action. They reduce production and increase the outflow of aqueous humor. Watch out for fatigue, dizziness, dry mouth, and hypotension. Allergic reactions are also not uncommon, especially with apraclonidine. Representatives of alpha-2 agonists are apraclonidine. It's used as a short treatment only for up to 3 months, and brimonidine. Brimonidine comes in 0.15% alpha-gun P and 0.2% alpha-gun brand. Both formulations have the same efficacy and are used twice a day. Alpha-gun P is formulated with a different preservative, purides, and seems to be better tolerated. The next class is carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are also the second-line treatment option. Various processes regulate aqueous humor production. One of them is through the enzyme carbonic anhydrase. Carbonic anhydrase inhibitors block this enzyme, which leads to a decrease in aqueous humor production. The drugs of this class are not as effective, require more frequent 2 to 3 times day administration, and have a bitter taste. However, they are generally better tolerated and cause less side effects. The carbonic anhydrase inhibitor representatives are brinzolamide and dorzolamide. Lastly, cholinergics or miotics. These are the third and fourth line treatment options. They constrict the ciliary muscle and therefore increase the aqueous humor outflow through the trabecular meshwork. They also cause miosis, leading to decreased vision in low light. We almost never see this medication in our practice. The only cholinergic available in our pharmacies is pilocarpine. Multiple drug combinations also exist. A beta blocker, timolol, comes in a combination with the majority of active ingredients. We've got combinations of timolol with prostaglandin analogs, with bimatoprost, latanoprost, and travoprost. Combinations of timolol with carbonic anhydrase inhibitors with brinzolamide and dorzolamide. And there is also a combination of timolol with an alpha-2 agonist, brimonidine. Carbonic anhydrase inhibitor brinzolamide and an alpha-2 agonist, brimonidine, also exist in a combination. In the US, there is also a Rho kinase inhibitor, nitarsudil, that is used either alone or in combination with latanoprost. Another newer drug, latanoprostene bunod, is a nitric oxide donating prostaglandin analog. All those medications increase the outflow of the aqueous humor by different mechanisms. Many new drug therapies now look at neuroprotection, preventing nerve tissue damage, rather than simply reducing the intraocular pressure as the treatment target. So watch the space, it's possible that we will see many more new drugs for glaucoma coming up soon. Useful tips to give to our patients regardless of the class of glaucoma eye drops they use. Wait at least 5 minutes between different drops, or if 2 drops are prescribed. Once you instill the drop, close your eye and press in the corner of the eye for about 2 minutes to retain the drop in the eye, otherwise you'll just swallow it. The correct technique is also minimizing the frequency of systemic adverse effects. Most drops in bottles last a month. Note the date when you open it and discard it even if there is still some liquid left. This is because the preservative will not be working well after this time and the drops may become contaminated. Single-use vials should be discarded immediately after use as they contain no preservative and may not be safe for use at a later time. If you wear contact lenses, make sure you remove them before using the drops. Wait at least 10-15 minutes after you use the drops before inserting your contact lenses. Some patients may not feel if the drops have been successfully administered. We may suggest keeping the eye drops in the fridge, as it is easier to feel a cold drop dropping into the eye. It should be explained to the patients that the medication will only work if it is used daily. The pharmacological treatment is usually lifelong, unless other treatment options are used, and if they stop using the drops, once the target levels have been achieved, the intraocular pressure will rise again. As pharmacists, we also need to keep in mind that some medications may cause an increase in intraocular pressure and may either affect the treatment of glaucoma or increase the risk of developing glaucoma. Some examples are cold and flu tablets containing pseudoephedrine, Some antidepressants, for example SSRIs and tricyclic antidepressants. Treatment with glucocorticoids for over 2 weeks. This includes formulations for ocular, oral, inhaled, and periocular use. Interestingly, according to Uppdate, intranasal glucocorticoids were not found to cause an increase in intraocular pressure, despite warning issued by the manufacturers. Other examples are antipsychotics, ocular vasoconstrictors, the eye drops for red eyes, and anticholinergic medications, such as SAMAs, LAMAs for treatment of asthma and COPD, antihistamines, and anticholinergics for urinary incontinence. Thank you for watching. Like and subscribe to keep up to date with Pharmtastic Form. Bye for now!